Welcome to Quality. This is your host, Arjun Venkatesh, where we're exploring quality in emergency care. Today is the next episode in our venous thromboembolism series as part of the Emergency Quality Network's VTE effort nationally. I'm joined by the co-lead of that effort, Dr. John Sather, as well as our special guest today is Dr. Lauren Westafer, who's an emergency physician and a PE researcher from Baystate Medical Center in Massachusetts. We're really lucky to have you here today, Lauren. Welcome to the show.
Thanks so much. Happy to be here.
I was really excited when we got you to say yes to come join us on the podcast because you're the lead author of the paper in Annals that in many ways I think of as this, the real most current expert review out there on managing PE. And I got to think, you've read all the papers, you've sort of seen everything that's out there. We have a lot of listeners that are clinicians managing PEs. We got a lot of quality medical directors. Were there a couple things from putting that review together that really stuck out to you as things we should all know in emergency medicine and our practice should really be up to snuff with?
Yeah, there are so many things, but I guess to hone in the major things that sort of I really wanted to get across was the diagnosis of PE has changed drastically. Like since I entered residency, 12 years ago or however long it was. And that's that we have probability adjusted D-dimers now and age adjusted D-dimers that can really hone in that population that we're really trying to figure out who do we need to take to the next step to send to the CT scanner. And I think the second is, when I first started, it was it's so easy. You see a PE and you're like, okay, easy, heparin, admit. And now it's way more complicated because number one, heparin is sort of a garbage anticoagulant. It takes forever to get therapeutic and everything. And so really figuring out what is the best anticoagulant, and it's easy. It's usually not unfractionated heparin. And then figuring out how do all the other treatment modalities enter in and how do we risk stratify PE? I feel like it's changing every minute. And you know what? It's going to be different next year. And I love sort of the cadence of that.
Lauren, thanks. And thanks for being on the podcast. I'm really excited to talk to you as well. Let's dive into that a little bit more. On the diagnostic front, you mentioned sort of you've been doing this for 12 years since residency. Let's get into some more details. What are some of the current challenges in risk assessment to determine pretest probability? I think of the years sort of approach and sort of has that reached the bedside? You work in an academic institution. Do you feel the residents are coming to you with sort of an understanding of how to risk stratify, how to use the D-dimer, how to appropriately interpret it in unique populations?
I think we're getting there, but only because they hear about it all the time from me. I would say that at most centers or many centers, that's not happening because we worry about it. PE is an emotional diagnosis for a lot of people. And doing some work in this space, it's like they can't miss. And we kind of forget about there's that 5 to 25% of CTAs that are read as positive for PE. They're actually false positives. And so I think that's one of the biggest hurdles to get over and sort of figuring out who to test and why to buy into some of these strategies that factor in sort of quantifying pretest probability and really figuring out who to scan is because you may give somebody a lifelong diagnosis of VTE who never had one. And so figuring out how do we convey that to clinicians. And I think we've done it at our institution, figuring out how do we get other people to buy into that is sort of maybe how we can move that needle.
That's a really important, I think, discussion about this idea of, false positive. And I think people have a very simplistic idea of it. Sometimes people think of false positive as, they called it as a PE and there was no PE there. It's just about the radiology read. But I think the frame you use is different. Your idea is that we false positive label somebody as having a diagnosis of a clinically significant PE. So that's inclusive of maybe a misread. It's inclusive of the, super subsegmental PE of no clinical significance. It's inclusive of, some of these other things. And I think that's a much more patient-centered way to think about it that I really like.
So I was also interested to talk to you, Lauren, about sort of the low-risk PE challenges. You're also lead author on two relatively recent articles, one in Academic Emergency Medicine in 2020 that really looked at the outpatient management sort of practice patterns, I think across a significant number of sites and patients. And then you did a qualitative study, which you published in Annals that looked at the barriers to what we consider to be evidence-based outpatient management. Can you talk about those two papers and sort of what you learned from them and where you think we are since you published them?
Yeah. So in the large database sample, we use the Premier database, and we wanted to know how many people are discharged. And I was shocked to find it was in the couple of digits. Sort of that was the proportion discharged from the emergency department. And then what was perhaps more interesting was when we looked at like what predicts who's going to get discharged and who's going to be treated as an inpatient or OBS or whatever. And of course, it's things like, yeah, you have a diagnosis of syncope or shock, like all of those things. But after you get out of like respiratory failure, syncope, and shock, it was which hospital you present to. So we did something called the median odds ratio that takes into account accounting for other patient level factors. What if the same patient were to present at two different hospitals, what are the odds? And that was one of the most predictive things. And so that made me realize like this is really not a patient level thing. Everyone's like, oh, my patients are sicker. It's really a culture of the hospital and what is perceived as the local standard of care thing. And so that's what we did that barriers paper to figure out like, why do we have such a hard time with this? Because people in Europe and other places have been doing this for a very long time.
And just to give some numbers, and correct me if I'm wrong, but I think the expected percentage of PEs diagnosed in the emergency department, we would expect about 25-30% of those could go home. And I think you found 5% or less.
Yeah, 4.1%, I think.
Yeah.
But yeah,
No.
and the range varied very big, but there was a lot of variation around that number, but we're not hitting that target of like 20, like you said, you're right on 25-30%.
And speak a little more about the barriers paper. That was a qualitative study. Sounds like you engaged clinicians. Did you engage systems as well? Was this interviews of providers, or were you talking to medical directors, hospital administrators, outpatient folks?
We talked to emergency physicians, and we did something called maximum variation sampling. So we specifically targeted people that discharged a lot of patients, that treated them as outpatients who had PE, who were sort of experts in it and did it a lot. And then we tried to sample from places that like, nope, never. And to figure out like how did people overcome that? How did they learn to do that? And what sort of is set up in those systems? So you might expect some of them like might be from a Kaiser-like system where they have those things in place, and others were from academic centers, and some were from rural centers. We tried to get geographic variation as well. And what was interesting is you would get two people from the same institution that were like, oh yeah, my patients, they're too simple. We couldn't possibly do that. And you'd get somebody else that'd be like, oh yeah, I discharged like 50% of my PEs. And so I think that was one of the biggest themes that we came across was people have this perception of like what everyone else is doing and some of the barriers. But really a lot of what it comes down to is like their self-efficacy, what they believe, and then what they perceive other people in their system doing.
So, that's really interesting because we have several of these equal collaboratives going right now. And one of the things I have sort of come to learn, even as like a big quality improvement person who's always thought about system, design a system and people will do it, is that in our stroke collaborative, one of the things that we've learned is when best practices get implemented, it tends to be I don't want to say top down, but it is very much a systems based intervention. And so people will say, oh yeah, our department is doing this. We take patients directly to CT for a stroke. We have a protocol in place to identify who needs a mechanical thrombectomy. And sort of the reason practice change happens is because they've structured the system as such. Contrast that with our opioid use disorder collaborative. One of the things we've learned there is when it comes to treating patients with OUD with buprenorphine, it's very much more this, I love the self-efficacy term you use, which is that, yeah, there's a champion, one person starts treating, other people start seeing it, they find that it's easier, then more people start treating. But when you just sort of put a system in place and say, hey, we do have follow-up, or we do have the meds and the Pyxis, that's sort of not enough. The system solution doesn't get you there. You sort of have to grow it organically amongst practice. What I'm hearing you say is when it comes to managing low-risk PE, it's really that latter, that we need to build that sort of individual practice change model, spreading the word type of care more than it's, oh, there's a system barrier. And if you just fix this with your, pulmonary service, you'd be able to do this.
Yeah, I think you're right on. And I think that there are two, if I could like do two main things. One, it's like win hearts and minds, right? That's what you got to do. You got to tell people like they may know, oh, the data says it's safe, professional society guidelines. They're like, oh yeah, that would help me do it. And I'm like, they've said this for many years, like that you can do this. That's not enough. They want to know that at their shop, their folks support it. And then number two, you got to make it the easy thing to do. Hassle bias is huge here. And the people we interviewed, even they sort of coined it. They're like, PE, slam dunk admit versus at places where they're like, whoa, this patient can go home. Why are you trying to admit him to the hospital? And so when something becomes harder, we're going to take the path of least resistance, whichever one that is. So there are system level things that I think would work here. But I think really getting people to that point of accepting it is big.
Yeah, and interesting in the way you described before. I think I would have thought prior to hearing you describe the differences that it was really institutional, where you look at the low risk discharges that are high hospitals and the low risk discharge on the other end of the spectrum, and fine, it was really a hospitalist. But you described that it was really practitioners in a similar institution or the same institution had widely different approaches. What do you think drives that? Is that risk tolerance, risk aversion? Is that knowing the literature? Why was one physician so likely to discharge so many of his PEs where another physician wouldn't?
People might come up with all sorts of things like, is this where they trained or whatever? And it wasn't any of those things. And to be clear, the institution was a big deal for a lot of people. But the other thing is we don't see as attendings often how other people are practicing within our own institution. We have a lot of assumptions about how they do. And sometimes people will get reputations through sign outs, or if you work in an academic department, people through the residents. But we often are sort of isolated to how other people do things and how they perceive data. And that was one of the big things here is the people that often said, I discharge a lot of people and I don't know what the other people are doing. They identified themselves as data driven. And that's, I think, another big deal because, again, going back to PE as an emotional diagnosis, if you've been hounded your whole life, the mortality is 18 to 30%, which it's not. Those were old figures. PE related mortality is like 1 to 3%. Then you are going to feel like, oh, I can't possibly send them home. 18% of them are going to die, 30%. And so if you're more up to date on the data, you may buy into that a little more easily.
That's a really good point. I think in some ways it's interesting because you say it's about getting people to buy into the data. John and I always talk about this all the time. PE might be one of the best studied diseases in emergency and acute care. Like we have better numbers for PE when it comes to mortality rates, when it comes to test thresholds, pre-test probability, post-test probability, all these other things that we do for anything else. Certainly better than stroke, certainly even better than MI. It's way, way, way better than something like sepsis, right? Because we actually have much clearer definition of what it is and what these numbers look like, but it has been really hard, you're right, to sort of change what people learn. I think often when they're in residency, it seems like that's where you're most sort of tied to your I always say your pre-test probability assessment from residency sticks with you for a while, right? How do we change that? How do we what we have a lot of listeners who are quality directors, medical directors at their site leading up new programs on PE care. How and what are the things they should be getting to their teams?
Yeah, I mean, I think that this is a problem with everything, though. It's just a little higher stakes, I think, with PE, both from if you overtreat or if you undertreat or sort of mistreat in one direction. And I think it's hard. We're talking about de-implementation. De-implementation is amazingly difficult for clinicians. It's the idea of discontinuing something that's low value, like a low value hospitalization. And it's hard because it's not even just the big stuff like PE. We do it all the time with things. You talk about how you learned diphenhydramine, Benadryl. It's the first thing people give to allergic reactions to anaphylaxis, even before epinephrine sometimes for hives. And it's been out of the guidelines for years. We have way better antihistamines that have fewer side effects, but we just can't do it because it's what we learned. And we think that it's stronger and better. And the same sort of thing happens with PE. We think unfractionated heparin is stronger and better. And so we need to get them admitted for that. When in reality, a DOAC often will get therapeutic or low molecular weight heparin more quickly. And so you don't need that hospitalization for the big gun anticoagulant, because that's all just a myth. And so I don't know how you, I'm working. That's my job as a de-implementation researcher, is to figure out how do we get that. But PE is hard because it's not just doing more stuff. Sepsis is mostly doing more. With PE, it's often been focused on culling it back some to right size the diagnosis, right size the treatment.
Yeah, I think, and Arjun and I have talked at length about this as a model for some of the quandaries we're sort of talking about. And I wonder if just PE management suffers from decades of very important PE diagnosis research, and then the hard work to get that research to the bedside. Meaning we spent, not, as a specialty, we spent 20 years trying to figure out who the right people to test are, and don't over test. And we're getting there, although, as we mentioned at the beginning of this podcast, there's some challenges. But I think we've just emphasized that so much that no one's really talking about or appreciating the data that's out there on the importance of risk stratification post-diagnosis. So what do you think about that as sort of a hammer to hit, or a nail to hit with our hammer?
Yeah, I think a lot of it is really getting people to understand PE. The PEs we're diagnosing have changed, right? We used to only have VQ scans or angiography, and now everybody, starting in the late 90s, everyone started getting CTs, and so we're diagnosing very different PEs. You can look at all the diagnostic studies that came out for Wells and all these things, and you're talking 20%, 1 in 5 CTAs had a PE. That's why mortality was so high. And now our spectrum of PEs that we're diagnosing has really sort of changed. And so our treatment needs to change as well. Certainly people do die of PEs, and we have thrombolytics, and now we have catheter-directed treatments. We have teams dedicated to this. But also there are those PEs that we didn't diagnose, 20 years ago, that we're now diagnosing, and they don't need hospitalization. They don't need to be bedridden even more, and all those things. And I think understanding that out of those diagnostic studies is really important, and looking at some of those numbers as to why it's shifted so much with regards to treatment.
Maybe for our audience, take us through how you, what your workflow is, maybe working in the academic setting with residents. So you have a patient for whom you've already decided based on pretest probability, your imaging, you get the CT read. The resident comes to you and said, the patient in room 4 has a PE. What are you thinking? What are your next steps, and how do you help the residents work through that to get to the optimal treatment strategy?
The first thing is confirming the diagnosis. There is a lot of literature, and another paper that was looking at sort of natural language processing algorithms just came out again, where 1 in 10 CT reads plus is uncertain, suggestive of maybe. So I sit down with the resident and I say, let's look at this. Let's look at the clinical picture, and let's discuss, was this the right study? Was it actually protocolized for PE? Is it actually a PE? Sometimes it's obvious. You're scrolling through and you're like, yep, that's straddling the main arteries. But other times you're like, I don't know. This patient came in with stroke-like symptoms. This doesn't really make sense. It's not the right study. So first I confirm the diagnosis. And then second, we're like, okay, let's go through. We have an algorithm, and I'm always like, let's go through the things that kind of are on our algorithm. And we sort of use a combination of risk stratification tools. People have compared them all. Most people have favorites. I use the one that gets more people out the door and is also super safe. That's the PESI. For my like, let's talk about risk. Does this patient need to come or go? Often it right off the bat, right? Sick or not sick. And then we can apply the PESing, sort of talk about what's this patient's risk of dying in 30 days. Still not, are they safe to go home? Maybe they're undomiciled. Maybe they, for some reason, don't have, they have a cognitive delay or something like that. And then we have some other criteria. And so I just walk them through the algorithm to try to teach them that, if you just make an emotional or mental decision, oftentimes it's not the place for that. We have evidence-based predictors, and I'm not too, I'm a PE researcher, and I still go to the algorithm because I'm going to make mistakes. It's like when I'm doing Wells or PERC, I still go and I plug it in every single time because I know it off the top of my head. But what if I'm wrong? What if I'm tired? I'm a nocturnist. That happens a lot.
That's a good point. I do the exact same. We develop all these toolkits around this. We're looking at this PE stuff all the time. And I worked last week, and it wasn't to even teach. It was just like me alone. And the resident told me the patient had PE. And so I went back and same thing. I pulled up PESI and went through the calculator, because I think you're right. It's a tool that's a good cognitive support tool. You're tired, you're distracted, you got a bunch of different things happening, and it keeps you organized. The other thing I found that it does is, sometimes you have a pretty good ability to make that initial pre-test assessment around, does this patient need testing for PE and which test? So you've already decided. Like, I see the patient, I'm like, yeah, we definitely need to test them. They're definitely going to need a D-dimer. And then you go on autopilot. D-dimer comes back. It's positive. You're on autopilot. I'm going to get a CT. CT comes back. It's PE. To me, what it does is you often don't ask some of the questions, or you haven't really looked through the medical record or quickly search for some of the things that are in the PESI as part of your initial eval of the patient. And so you actually need it, I think, to go through it and be structured about it, because you've been on autopilot for the last 2 or 3 hours based on how fast you can go through that workup at your shop, to almost, I don't want to say start fresh with the patient, but the management decision is like it's a different point in the pathway or the algorithm. And you need to have that fresh start for it.
Yeah, I almost think of it as there's 2 diagnoses embedded in the diagnosis of PE. When a patient comes with belly pain, you're wondering if they have appendicitis. Once they have appendicitis, you're done on the diagnostic front, right? But with PE, you need to make the diagnosis of PE, and then you need to make the diagnosis of what type of PE, and then determine management. And that's a really hard thing. You mentioned the autopilot, but that's really hard for emergency medicine physicians who are kind of managing a lot of patients at the same time to regroup and go back into diagnostic mode again.
And it's changing. I mean, our classification, I still hear massive and submassive all the time. And like, we've moved on from that because that was the dichotomy wasn't good enough. And we've moved to the European Society of Cardiology, low risk, intermediate low, intermediate high, and high risk. And you know what? It's probably going to change in another year. And so when things change so quickly, and this is one of those realms with regard to like advanced treatments and even anticoagulation and stuff, you got to have something else to consult, because there's got to be something better than the risk stratification tools we're using now. And it's only a matter of time till it's out and it's better. And so I want to be primed to be able to go and consult it rather than being so tied to the specific tool that I'm using.
Yeah, and from a quality improvement perspective, what I always say is like, we're trying to do the best with the information we have today and the resources we have today for the care of that patient. And so I think actually accepting, and everybody hearing what you just said, which is we've changed how we do this risk stratification from the way we did it, and it's probably not going to be this way in the future, but this is sort of the best of what we have today. So go with this for now. But if you don't stress about trying to memorize it and be able to master it, but rather just use the tool in an easy way, the low hassle way, which is to open it up, go through, risk stratify that patient, pick the treatment, then if that's your habit and that's the way you go about doing it, you'll do it that way 2 years from now when the risk score changes. You'll just flip which risk score to. I like that. Lauren, this was amazing. Thank you for joining us today. I hope that our listeners today sort of walk away from this in charged, emboldened with that self-efficacy that you were talking about to do this, because I do think there's a lot of patients and EDs around the country, particularly those that are in our equal EDs, who would really, really benefit from getting that accurate PE diagnosis and having that direct the kind of treatment they get. Often when we have great speakers like you on, I give everybody the soapbox at the end. And so you've got the audience, you've got all of our equal clinicians out there. Is there one thing that you want to make sure everybody hears? You're the expert. And so I'll give you the last word.
Okay. If you're trying to implement this, one of the biggest things you can do to make it easy for clinicians is have a pharmaceutical rep. I'm not sponsored by industry. Give those coupons for DOACs or whatever anticoagulant so that the patient can get it. Clinicians were really stressed about prior authorization and insurance. And the truth is you don't have to worry about that. You just write a 30-day script. And a lot of these companies will give you free coupons or copay. So you don't have to worry and stress about, can the patient fill it? Do they have insurance? It's all taken care of for you, tidied up so that your clinicians can sort of discharge patients with anticoagulation for at least 30 days.
Awesome. So don't let the myths send you in the wrong direction.
That's right.
Thank you for joining us. This is great. Hopefully we'll have you back again in the future.
Thanks.
Thanks, Lauren. It was great.